experiences, but also some cutting edge information on managing pandemic risks in health facilities. So maybe just a few words from the perspective of somebody coming from the disaster risk management community. What we have seen with the COVID-19 pandemic is that the existing strategies for pandemic risk management in many countries were really not adequate in terms of dealing with the impact of this emergency, because the impacts extended beyond the health sector. And it's what we in the DRR community call a systemic risk. And in terms of the systemic risk, we need new ways of managing systemic risk, which go beyond the approaches we've been using in the past, in which much of the management lied with national disaster management agencies. So one of the points I would really like to stress today is the need for us to continue to work very closely together to break down what we often see are silos at a country level between the healthcare systems and sector and the national disaster management agencies. And what we have been seeing in several countries is that working closely with the disaster management system has allowed this wealth of experience and technical knowledge to come to the forefront to help strengthen health systems, whether it's in helping to design business continuity planning for hospitals, or helping to conduct risk assessments, or even managing emergency operations centers. And these are just a few areas where we see a strong collaboration as yielding some real benefits. Maybe just to remind everyone that in 2016, there was an international conference on the implementation of the health aspects of the SENDAI framework for disaster risk reduction, which for those of you who may not be familiar, it is the global blueprint for reducing disaster risks. But in 2016, there was a consensus developed around what is known as the Bangkok principles. And what these principles call for is far better integration between disaster management and health systems. Now, at that time, the Ebola epidemic in West Africa and the Zika virus outbreak were really demonstrating a need for a multi-hazard approach to strengthening health system resilience and integrating health emergencies into disaster management systems. And we have certainly seen through the COVID-19 pandemic how really urgent this integration and stronger collaboration is. Now, the good news is that we have seen in many countries that pandemic governance structures have been established that are truly multi-sectoral. It includes the health ministries, disaster management agencies, but also a spectrum of other ministries that also are obviously impacted, whether this is education or agriculture or others. So it is our hope that these types of multi-sectoral approaches to governance will continue even after the COVID pandemic and play a role in hopefully preventing future pandemics and other types of emergencies. I would just like to mention that we are working quite hard to ensure that we do a better job in our national and local DRR strategies to integrate health considerations. And we know, for example, that there is a real need to strengthen our understanding of health risks when we design national approaches to disaster risk reduction, and that we are working really to strengthen coordination and mobilize partnerships. Now, the Bangkok principles is one guidance that I mentioned, but I would also really like to promote the World Health Organization's Health Emergency and Disaster Risk Management Framework, which is very much in alignment with the Bangkok principles. And these are really useful sources of guidance to be used in the field. One other additional point is that we are just now finalizing a supplemental guide on integrating health emergencies into DRR strategies and plans. And this is really with the aim of providing the disaster risk community with more targeted information on how to help them better consider and address the risks of disease outbreaks and health emergencies. And at the local level, we are working also with WHO on making available a public health scorecard addendum, which is being disseminated through a self-paced capacity development program. So you can see that there are real efforts underway to ensure that throughout the continuation of the response to the COVID crisis, But also in preparation for future health emergencies, the disaster risk management community is really working side by side and hand in hand with the health community to ensure that the impacts of these disasters are minimized to the extent possible on populations. So thank you very much. I look forward to the outcomes and the lessons learned today.
Thank you, Ms. Heiber, for the remarks, and thank you, colleagues. I can already see in the chat box lots of greetings from colleagues from all over the world, from Surabaya to Lisbon to all ends. Welcome to you all. As we go through today's session, to today's webinar, feel free to ask questions and insert your comments in the Q&A box that's available. We really heard some wonderful comments from these opening remarks around the need to address the systemic risks, the worthwhile and beneficial engagement of working together, and how to break down the silos. So today's webinar, I really thank those three speakers for bringing that and putting that together for us. And today's webinar will be conducted in 3 interrelated sessions that build on this. The first session will focus on country experiences, the hospital and health facility experiences. The second session will focus on lessons learned from the COVID-19 pandemic and considerations for hospitals of the future. The third focuses on the contribution of innovation, research, and continued learning that can enhance the preparedness of health facilities and hospitals. Now, with all of this said, we do have a challenge today. And that is time. We have an incredible constellation of speakers who will share their key headlines from their vast knowledge, experience, and wisdom. And I ask speakers to stay within their allotted time, and there will be plenty of questions and answers in that box. I hope that we can stimulate from the participants today. We really would like to use this opportunity to forge relationships, build the linkages, and exchange and have those exchanges that are beneficial to us all. So without further ado, thank you, distinguished speakers. Thank you for your guidance and inputs. Let's get started. Session 1. Session 1 focuses on hospital experiences in countries facing emergencies from multiple hazards, including the impact of climate change during the COVID-19 pandemic. We have 4 speakers in this session from diverse sets of countries: France, Indonesia, Kenya, and Italy. Each speaker will present for 6 minutes on their topic. And without further ado, may I now invite Mr. Alexander Mokede, head of the Healthcare Organization Unit, French Hospital Federation in France. Mr. Mokede, the floor is yours.
Thank you very much, Doctor. I'm glad to be here, and I'm really grateful for the invitation. I am honored to present what we experienced during the COVID-19 pandemic in France. I am Alexandre Mokede, and I represent the French Hospital Federation, which represents all the public services hospital in France. So, COVID-19 pandemic in France. What are we talking about? A small amount of key figures. More than 5 million people were tested positive for COVID-19. We had 300,000 people hospitalized and more than 8,000 people in intensive care at the same time. That was the main challenge, and I'm really sorry about the noise, but I didn't see my neighbors. I needed some quiet time at the time. Sorry about that. So more than 8,000 people were in intensive care at the same time. That was a huge challenge because in normal time, we have only 5,000 beds that are available for the people. And today we have 100 and 1,000 dead people due to the COVID-19 pandemic. That's a lot of people, and we are really sad about that. So the question was, what kind of risk management did we have in front of this situation? The first question I would like to answer is, what kind of risks were we prepared to? And to be honest, we were not prepared for such a pandemic. We were prepared for a short crisis with a great amount of victims on a small scale. For example, a terrorist attack. For example, you may remember the terrorist attack in Paris in 2015, I think. It was 200 or 300 victims, and we were prepared for that because we have what we call a plan blanc, a white plan that allows us to put together all the resources of the hospital for a short amount of time to answer the crisis. Or we are prepared to face a long crisis, but with a small amount of victims. We were not prepared for such a crisis with a lot of people involved and a very, very long time. It's been a year now, and the healthcare system is under a lot of stress because of that. Our system is not done for such a long crisis. So this leads us to think that we have a limited resilience to climate change risks because of this risk management system. The kind of risk we have to manage in normal time is not a huge scale risk like the COVID-19 crisis. I would like to move to the next. Thank you very much. So what were the strengths of our healthcare system that allowed some resilience to the COVID-19 crisis? First, we had a national vision of the crisis. We have in France a very centralized system that seemed efficient to avoid a total saturation in the most targeted regions. Because what is important to know is that in the first wave, only a few French regions were really, really touched by the COVID-19. Some of the other regions were not under such a pressure. So we had this national vision which allowed us to see where the problems were, and where we could send the people that were ill, that were affected by the disease, to unleash the pressure, on the hospitals that were on the first line. Secondly, we have a big network and a care spectrum that can allow us to organize the system into 3 lines of hospitals who can take patients who need really intensive care, and home care. That was really precious because we could focus the energy on the first hospitals who had to treat the more severe patients. And we had a really strong coordination between all the hospitals and also the general practitioners who can go to the home of the patients to make sure every kind of patient is really good treated. Another very good strength was the proof of adaptation and solidarity between all the professionals, and that was the key to the resilience. Really, I would like to insist on this point, because we had the capacity, and the professionals had the capacity to be really together and to have a strong power of adaptation, which allowed us to multiply by a factor 2 the number of beds for intensive care capacity. We went to 5,000, from 5,000 to 10,000 in 2 or 3 weeks. And that was impressive, and we did not believe the professionals could do it so quickly. And it was allowed by more than 60,000 healthcare professionals who came to help in hospital. People who are normally not in the hospital, who volunteered to come in the hospital and say, I want to help. I want to go to the hospitals to treat the patients. And thanks to this mobilization, we could overcome the crisis. And the last point was a strong inclusion into the economic fabric, because like most of the other countries, in some weeks of the crisis, we lacked almost everything. So some fab labs in hospitals were put to product personal protective equipment, and that was really precious for our professionals, so they could go to work to treat patients with the good gears they needed. And secondly was also the cooperation with big industries to produce respirators. And it was really precious also because, like other countries, we didn't have enough respirators to have 5,000 more intensive care beds. And that was one of the strengths of our healthcare system. But the crisis also highlighted a lot of weaknesses that we have to think about in the future, but you will see that in the next session, I think. Some weaknesses highlighted by the crisis. First, the system relies too much on healthcare. I mean, health, if I want to be a little bit provocative, health is nothing about healthcare. Health is all about prevention, health education, and environmental health. But in France, we have a system that says we must focus all the resources on the healthcare, on hospitals, on practitioners, and we have basically no prevention culture and not enough health education. Because the problem is not that the healthcare system cannot handle that much patients that need intensive care. The problem is that so much people need intensive care in the first place. The countries that were really successful to overcome the pandemic were the countries where people just didn't go to intensive care. And that was the key. And that is something we have to learn for the next epidemic that is really likely to be. The second weakness is budget cuts in the healthcare system. Because if you rely on the healthcare system, you must not cut budgets in the healthcare system. And in the past 10 years, we experienced in France 12 billion euro budget cuts out of 1,000 billion euro budgets in general. And it's huge because the system not only was not prepared for such a crisis, but we were weakened before we even entered this crisis. And the third weakness that was highlighted was a bad articulation, because the science fields and the political field, if you have to manage a crisis, you have to inspire confidence. If the science field and the political field is not in a perfect alignment, the population doesn't have a lot of confidence into the political choices that are made. So what we learn about that is that everything about the science field and the political field has to be transparent. We need to improve transparency in the management and the decision process. With that, we can have the confidence in the population, because with this confidence, you are sure that the population can obey what is said to her. For example, all the orders about social distancing, about mask wearing, about everything, you need this confidence to have obedience. So what are the lessons and the perspectives about this crisis? First, emerging infectious diseases are likely to multiply due to the climate change. There are new animal vectors like the tiger mosquito, which is a really great concern in France, not today, but when the airlines are open again. it's a really great concern. And we think that is the source of a next pandemic, maybe in France. And for that, we have two duties: mitigation and resilience. To mitigate the climate change, we have
Mr. Mokede, if I may interrupt you to wrap up, please. Apologies,
yes.
With 6 minutes only.
Oh, sorry, really quick. We have to be more environmentally responsible in the hospitals, and the presentation shows how we have some progress to make. And at last, I would like to insist on resilience. First, stop budget cuts in the healthcare systems, because we need to have a budget that is based on the population's needs and not based on the possibilities of the states. Secondly, we have to invest on prevention and health education. This is a really important point, and this is the key for the next pandemics. And third, we have, as I said, to work on environmental health, to work on the climate change challenges. Thank you for your attention, and I'm sorry I take too much time.
Thank you, Mr. Mokede, and it's a sobering reality that you've just presented, and it's indeed a topic that one could discuss for many hours. This was a really fantastic way to showcase what the reality is on the ground.
Thank you very much.
Invite Dr. Lydia Okutoyi, Director of the Healthcare Quality Group, Kenyatta National Hospital, Nairobi, Kenya. Dr. Okutoyi, over to you.
Thank you very much, Dr. Gina. Thank you for the introduction. I work in Kenya. On the map, it's in the Eastern Africa, and at a hospital, a national referral hospital. Next slide. Yes, so we are currently experiencing the third wave in Kenya, and the third wave is coming down. I think daily we have slightly less than 500 positive cases. This far, we are almost coming to about 120,000 cases. And per day, we are seeing that the mortalities are also coming down about 15 to 20. And that has been fairly high for our country because all our ICUs are full, especially those that are dedicated to COVID patients. So our system have been thoroughly exposed, and the resilience that we so need or needed to have had at preparation is being exposed. That is something we have to continue in building in our system. So we've also had the launch of COVID vaccination. That is a month ago. It was prioritized for healthcare workers and those over 58. And that is ongoing amidst a little bit of hesitancy. This for our population, we've only vaccinated 2%. We hope that we get towards 10%, and we will be needing more of the vaccines. Currently, we have vaccines that have been given courtesy of UNICEF and WHO, but we will be procuring some as our country. So we're having lockdown during this third wave for the 4 red zones within our country, and so there's economic implications. Those who earn below $5 per day, there's a lot of struggle in that segment, and people are not happy with the lockdown, but this is where we are as a country. Next slide. So the next slide is just a picture of the launch we had for the AstraZeneca vaccine, courtesy of the 2 organizations. We are seeing that a lot of the hesitancy is because of us not understanding on that there'll be some side effects that very few of the populations will encounter, but most of the people who are afraid, even the healthcare workers, is because they suspect that they may get the adverse effects that are seen on the media. And worse is the complicated relationship between the UK and its neighbors. And so when AstraZeneca is on the media about clotting and such, then we get a backlash. As a country, we continue debunking those myths And among the healthcare workers, our institution is trying to ensure that we are monitoring the serious side effects. This far, we've had actually 1 or 2 serious side effects. Most of them have been very minor side effects. We are about 500 healthcare workers and those who are vulnerable vaccinated. Next slide. So our hospital is a national referral hospital. We host the University of Nairobi Medical School and Middle Cadre Medical Training College. We have about 2,000 bed capacity. Our workforce is 500,000. Combined with the ones from the university, we could get to about, 8,000, not 500, from 5,000 to 8,000 if we combine the lecturers and the residents who also offer care within the institution. We also have a large maternity and theater capacity, about 26 theaters. And I head a division called Healthcare Quality, where we actually support, we do health system strengthening at the level of the hospital to ensure that the care provided is safe and is of high quality, addressing complaints, addressing waste management, addressing IPC. We also address looking at medical errors and being able to do root cause analysis. And at the same time, we also support any other system improvement that needs to be done. I'm a gynecologist by background, having done public health. And so we are together with nurses and doctors. And we also have been redeploying employees during this current pandemic to the areas that they are most needed. And some of the challenges that we've encountered is need for critical care support. As we speak, we have a new facility that was about 72 beds, capacity for high flow oxygen, but proper ventilatory support for COVID patients is limited to below 20 beds, which is very minimal for us because we are a large institution. However, the rest of the critical care beds come to about 56 through the hospital. So our approach during the pandemic is to be able to expand the services when they are needed and to be able to shrink so that we don't have redundancy, and also to support the additional testing and laboratory services that were required. We initially had a problem with the PPEs, but we had a proactive procurement for the same, plus from donors and well-wishers, we've been able to have correct and adequate supplies of the protective and preventive equipment. Next slide. Next slide. Thank you. So the leadership has had to face some challenges, both locally within our institution and to lead the country, the response, because we are the national referral hospital. So we needed to support also capacity building together with the Ministry of Health to the other counties, and the need for extra space required that we are able to have some areas that were functional in different manners being shrunk. And like currently, one of the approach is that we only have we have 2 negative pressure facilities. And so one of them is for MDR TB, which has a bigger capacity than the COVID. So the need for space is that we will be able to change and to have the COVID response ICU to move to the MDR TB. And then also another challenge was rumors and misinformation. At the very beginning of the pandemic, my division supported the institution for timely sharing of information, just in how do we prevent COVID and what are the precautions that we ought to take. And then also we needed increased staffing in those areas. As we realized more than ever before, we needed nurses trained in critical care, yet we didn't have enough. So to address this, the leadership had our intensivists and the COVID response team offer trainings for resuscitation, for intubation, and for just emergency care. And then also we had a challenge with the transportation of our staff. Since there was so much stigma, it was difficult for our staff to get from work and go to public transport, and we thought that would expose them too much. So we had to organize transport and also address matters of anxiety, because whenever there'll be one staff who's COVID positive in an area.
Dr. Lydia, if
yes.
I may interrupt you and ask you to wrap up, apologies.
Great, next slide. So Yeah, just a bit of guidance that we have offered within our institution. We supported the IPC guidelines. We got about 22 of them, from zoning up to case management. Next slide. That is some of the capacity building that we had in the neighboring counties hospitals who are training them on IPC and COVID management. That is from our national hospital to the other sub-regions. Next slide. I think I'm about to finish. We also had opportunity to start proper utilization of our microwave equipment. As you realize, COVID, we have a lot of waste that are coming from all these hazmat suits and the gowns. And so being able to use the microwave equipment is something that has been good. And also we've been training and offering webinars. Like every Friday, there's a case management webinar that goes all the way to the regions with more than 1,000 participants, for which the hospital has used the platform of the webinars to disseminate and give opportunity for training. The last slide. Yeah, just COVID has exposed our strengths and weaknesses at a global and regional and local levels, and more than ever, resilient health systems are required if we are to have the desired outcomes for our population. Thank you very much.
Thank you, Dr. Okutoyi. I really appreciate these comments. And again, it comes back to scalability. Let's shift to Mr. Diego Lauritano from the St. Ursula Polyclinic in Italy. The floor is yours. 6 minutes. Apologies for the time limitation.
No problem. Let's wait for the presentation. Well, welcome to everybody. Good morning, good afternoon, and good evening, since we're all from all over the world. I speak from Bologna. Next slide. On behalf of my colleagues, Bologna is in the region of Regione Emilia-Romagna. You can track a number of data coming from population in this slide. I'm quite hopeful that you will have the presentation so you can further read it if you might lose something in this moment. Bologna metropolitan area accounts for around roughly 1 million people. Next slide. This is showing the campus of the hospital. You can appreciate this is a block of Bologna, more or less, medieval city. And you can also see, I hope that there are around 32 pavilions in the campus itself in the city. So it's a block of Bologna and a block in itself. So next, please. It was founded in 1592. That is around when Elizabeth I inaugurated the Trinity College, I think. This is a university and public hospital and a scientific institute, 1,500 beds and more than 5,000 employees. Just to give you a few data you can review on volumes. Next, please. And this is the first of the 3 arguments I would like to underline to you in this session. First of all, we had, of course, like everybody else, have to give a quick reaction to the COVID-19. Our first approach was to dedicate an entire pavilion, the number 25, which was luckily enough empty because on the verge of renovation. And so we were able in immediate time, in a few days, to start up 35 COVID beds. And this was a very prompt reaction to our very first moments of pandemic in a year ago. I have enlisted a very few key issues that we had to face on this very first time, and I think that everybody can relate to those issues, ranging from ventilation to how you have to deal with waste management and over. And as the colleague said before, PPE and many other issues. Next, please. Well, a couple of, just a slide to show you how situation was in the beginning. And next, please. And today we, on the 28th of March, we had the peak of the 3rd wave. Let's say that Pavilion 25 has now reached 105 COVID beds. And we have renovated around 8,000 square meters of this 3-floor pavilion. So we ended up working a lot on the pavilion itself, and the hospital now accounts for 43% of the ICU beds of all the metropolitan area. And the metropolitan area itself counts around 1,500 beds. Next, please. Second aspect to bring to your attention, we were lucky enough to have a field support through WHO through TECNE, and we have started a WHO case study here on the field named the Hospital of Tomorrow. You can track the rationale more or less. We needed to find new standards to be redefined in the activity of the hospital versus the pandemic that we were facing. And the objective was to try to support this changement, and the findings of this case study we hope will be useful for other settings and to be scaled up. And next, please. This is how we did it and how we're doing it right now, because we're still on the field with this process. We started in May 2020 with the field support I was talking about before. Then we approached the case study as a proposal with the colleagues of WHO. And we started this process that led us to a bottom-up engagement after the first direction given from the hospital director to have a logistic frame in which we could work, and engagement with the kickoff of a number of working groups dedicated to specific issues. I will talk about them later. And these working groups have been evaluating a lot of projects and response to the issues that we had during the first pandemic, and up to now a number of projects have been set into place and brought to the executive board to be placed in action. So this is, we are already seeing the fruits of this thing. Next, please. Here again, you can drill down to what the working groups issues are. You can see we range from telemedicine to high-tech logistics to wayfinding, visual management inside hospitals in this area, for instance, and a number of other issues. These working groups are really related in between them, and this is a key feature that I will talk about in the ending of the slides, because it was really, really important for us. Next slide. And the third item is beyond. Piano direttore. Piano direttore, I don't think we can translate it. It would be the plan of the director. This is a strategic planning document we have, and we had in place before COVID, in fact, and aims to develop facilities in a certain model. It's planning that stretches from 2020 to 2030. So it's quite a range in period, and trying to focus and to cluster in buildings different healthcare activities. This is done by means of, let's say, consistently with the organization of the company, with the needs of the territory itself, Bologna City and the area, metropolitan area, and regards, of course, the building, the systems and technology that we already wanted to implement for the issues we already knew about in the healthcare. So let's say what we already knew about our own job. And this approach, implementing, especially integrating a lot of stakeholders in this terms, like the metropolitan network that I was talking about, the area metropolitan, so more hospitals together, but also the medical excellence that we have in the hospital, together with the scientific research. This was already ongoing. Next, please. It fits quite well because of sustainability. The Piano Direttore itself, in terms of our environmental and operational management, was already aiming for this. So we had the criticality assessment for urgency and emergency embedded in this document. And we had, and we're going to have, because this is for the future too, rationalized and flexible logistic flows for mostly anything, for patients, for visitors, for staff members, for technical crew, for students, because we're a university too.
Mr. Loretano, may I ask you to wrap up?
Yeah, sure. And so safety, helmets, and a number of issues that I'm sure you will be able to read. Next, please. And last, this is the 3 layers that we tried to evaluate. So we had the experience, harsh for COVID, but we have it now, and we're still using it, unfortunately. We had the dialogue that WHO and TECNE help us to put in place. That was a real asset for us in this moment. And of course, the piano direttore that sums it up and gives us the planning not to forget what we have done up to now and giving it to the future for better solutions. Thank you.
Thank you, Mr. Loretano. That was really enlightening. And I think the case study and the integrated planning that you're taking, you're getting a lot of queries and Q&A box inputs asking for your slides. So I think there's a lot to learn and share here. Thank you very much. Dr. Wiko Adisesmato, welcome from Indonesia. Salamat malam, Bapak. Good to see you again. And over to you.
Okay, thank you, Dr. Gina Samaan. I hope that I can present with my the newest version, but I'd like to present it. Please show the slides. Otherwise, I will use mine. Okay.
We'll see if it's feasible with the webinar format. Stand by.
Okay, for the time being, just waiting. I'd like to mention about the situations in Indonesia, as I'm the spokesperson of the COVID-19 task force in Indonesia. And there are a lot of experience that I've been doing for the last 1 year dealing with the COVID-19 mitigations in Indonesia. Right now, in a daily case, one day, yesterday, we have 5,600 new cases, whereas the number of the active case at this moment is 108,000 or 6.8%, and compared to the world case is 17.4%. And then the number of the recovered case right now is 1.4 million or 90.4%, which is higher compared to the world is 80.4%. But the number of the death cases is 42,900 cases at this moment. And the case fatality rate is 2.7, a bit higher compared to the world is 2.2%. Next slides, please. And if we look at the situations in the world right now, many countries have more new cases and uprising in terms of the cases. But in Indonesia, luckily, the cases has been reduced for the last 2.5 months because of the multiple policies that have been implemented with the restrictions of mobility of the people. And then if we look at the Indonesia COVID mitigation focus and from the curative and then switch to the prevention and promotion, and we hope that we can combat this COVID, and this is our modality for a long-term battle with the COVID-19, more on the prevention and promotion rather than on the curative. But of course, I will mention about the hospital aspects of it. Next slides. And if we look at the Ministry of Health technical guidance on the hospital service during the new normal, we have been improving our healthcare service flow by improving patient flow and then screening and also triage. And then where the innovation of the healthcare service also has been implemented with the online registration, telemedicine, and electronic medicine prescriptions also delivery. But of course, these are in the hospitals that are located in the big cities. We have 34 provinces and 514 districts and cities across Indonesia. So that's why we are dealing with the big healthcare systems. And then we, in those hospitals, we divided into 2 zonations for COVID-19 zones, and sometimes they have different buildings that is dedicated for the COVID-19, and then the other is for non-COVID-19. Next slides. And these are the hospitals that we are building, field hospitals, regional public hospitals, and also referral hospitals. One of the biggest converted new hospital is WISMA ATLET or guest house for athlete, and then we converted into emergency hospital with more than 10,000 beds over there. And also we dedicated hotels, rooms for isolations. Next slides. And if we look at the bed occupancy ratio of the WISMA ATLET KEMAYORAN Emergency Hospital, it has been reduced from time to time. So this is a good sign, where with the board difference is minus 45%, which is a big decrease in Indonesia. there was emergency in the last year, which is around December. Next slides. And you can see here that the number of beds compared to the bore has been reduced, and we hope that we can maintain this for a long term. But of course, it's a big challenge, because this month is a fasting month, Ramadan, and by the end of the Ramadan, then probably there will be more people mobility. But in terms of the policy, we restrict the people mobility during the Eid al-Fitr. Next slides. And if you look at the bed occupancy ratio, most of them are below 70%, and we have been working very hard, and finally we can suppress all of the cases across Indonesia and release stress for the healthcare workers. Next slides. In terms of the number of the laboratory networks across Indonesia, it has been increased a lot during 1 year. And then there are 12 ministries and institutions who are dealing with these laboratories. From 1 laboratories, and now we have 764 laboratories across Indonesia. And these are the numbers of the people who are being tested, and then also the positivity rate right now is 11.7%. Next slides. And these are the picture of the change in performance of the hospital in dealing with the COVID-19, and the healthcare facilities now being accustomed to the handling the COVID-19 patients. So that's the situations in Indonesia. Next slides. Okay, so that's the end of my presentation. So thank you very much. I hope that you enjoy with the materials, and hope that I can entertain your question and answers later. Thank you, Dr. Gina.
Thank you, Professor Wiku, who is the lead of the expert team as well of Indonesia's National Task Force for COVID-19 mitigation, and brings a wealth of experience from that perspective of government advice. Thank you. Colleagues, we've heard from 4 countries, their unique perspectives, the need for scalability, the need to think ahead, and also planning that's integrated and also cognizant of sustainability aspects, smart, scalable, and being agile. We are seeing a lot of questions come through the Q&A box. We hope that our speakers can take a moment also to see if there's opportunities to address some of those questions, as we now move to the second session of today's webinar, which focuses on the lessons learned from the pandemic and their application to strengthen hospital capacities. We'll hear about how the ecosystem of stakeholders, including governments, specialized entities, partners, and communities, need to come together to make this happen. The distinguished speakers of this session are from Climate and Health Alliance, UIA Public Health Group, and the Climate Change and Health Unit of WHO. Speakers, a reminder, you have 6 minutes for your presentation, and I have the pleasure to welcome Ms. Fiona Armstrong, the Executive Director of Climate and Health Alliance Australia. Over to you, Ms. Armstrong.
Thank you very much, Gina. Thank you for the invitation, and congratulations to the organisers for this event. I'd just like to begin by acknowledging that I'm on the land of the Wurundjeri people, the traditional owners of the land on which I live and work in Melbourne, Australia. A little bit about Climate and Health Alliance. We're an alliance of 55 member organisations, of which Australian Healthcare and Hospitals Association, member of IHF, is one. And we have a mission to build a powerful health sector movement for climate action and sustainable healthcare. Next slide, please. Our pillars guide our work. And I'll be talking a little bit about the 4th pillar, that's our goal. There's many leading examples of health services in Australia and New Zealand where we coordinate the network, who are working towards safe, climate resilient and environmentally sustainable healthcare. We're very excited about the work National Partner Healthcare Without Harm of the global roadmap for healthcare decarbonisation that happened today, which sets out how the health sector can get to net to zero emissions with 7 high impact actions. And I'll share a link in the chat. But now I'm going to share a few brief examples of some of the outstanding work that's being led by Global Green and Healthy Hospitals Pacific Region members. Next slide, please. Next slide, please. The Hunter New England Health Service in New South Wales in Australia is a large public health service with a large metropolitan centre and a mix of regional centres and small renewable centres. Just back to the previous slide, please. Hunter New England Health Service recently committed to being carbon and waste neutral by 2030. If we could, thank you, excluding clinical waste. So this goal that they've announced is groundbreaking for Australia, although it is in line with the kinds of action that we need to see. There's a link here to a short video on YouTube that you can look up later. The reason that they've made this commitment is the recognition that as health services, we need to first do no harm. And the board and executive of Hunter New England understand to protect the health of the community, they need to make sure that the health service isn't contributing to the problem. So they plan to make significant investments in solar over the next decade. They'll install solar, and including John Hunter Hospital of any hospital in Australia. They will transition their fleet vehicles first to hybrid and then to pure electric. And install e-charging stations, video conferencing to reduce unnecessary travel, and the service will make it easier for staff to carpool or ride their bikes to work. And when they travel, they'll support them to identify greener accommodation.
Ms. Armstrong, if I can also interrupt you, if I can interrupt you, we're having difficulty hearing you. Can I suggest that you turn off your video just to enable a better bandwidth? See if it works. Thank you.
Sure, no problem. Next slide, please. So the next example is from the Australian Capital Territory. The government in the ACT has committed to ensure that new government buildings are all electric. The electricity grid in the Australian Capital Territory is already 100% renewable. So that means that these buildings will be powered by 100% renewable energy. This includes public hospitals and health facilities, with the government recently announcing their upcoming Canberra hospital expansion will be 100% electric and renewable powered. The hospital will provide a new emergency, surgical and critical healthcare facility spanning 40,000 square metres, which will use an all-electric plant, including heating, cooling and lighting equipment. The greenhouse gas emission savings are in the vicinity of 1,886 tonnes each year, equivalent to taking 760 cars off the road. Next slide, please. The next example, Epworth Healthcare, is a large not-for-profit private hospital in Victoria who have committed to reducing food waste in their service. An audit of waste at one hospital found that food waste accounted for 30% of the total volume of waste, but 73% of total waste by weight. So they've installed a food waste dehydrator, which has reduced 43,000 kilograms of food waste to 12,000 kilograms of residue. This food waste residue is being sent to the local water facility, which is feeding their anaerobic digester, which is turning food waste into energy. And as of February this year, the food waste from Epworth has generated enough green electricity to power 2,013 homes for a day, or 6 days. Next slide, please. The final example is from Ambulance Victoria. Ambulance Victoria witnessed firsthand how climate change is impacting the health and well-being of their community, and they have a commitment to the community to reduce their contribution to climate change in line with science-based targets. They've entered into power purchase agreements to secure 100% green power for their larger sites, leading to an overall emissions reduction. They plan to move completely to renewable energy by 2025, and they've set and 2 emissions, and have brought forward their net zero emissions target 5 years earlier than originally planned to 2045. These targets mean that Ambulance Victoria will halve the carbon impact of each of the patients that they serve. They'll achieve these commitments through the use of renewable energy, retrofitting buildings with solar and batteries, adopting hybrid vehicles, and transitioning to zero emissions vehicles.
Ms. Armstrong, if I can interrupt you to wrap up as well. Thank you. Time is nearly up. If you can wrap up.
No problem. This is my last slide, and just one small snapshot of some of the incredible leadership from hospitals and health services in Australia who are working towards climate resilient and environmentally sustainable health care. Thank you.
Thank you, Ms. Armstrong. Those were some ingenious ideas there from the Epworth group, Hunter and Victoria region. Thank you for that. And let us now turn to Mr. Ray Pentecost, who is the director of UIA Public Health Group in the US. Mr. Pentecost, the floor is yours.
Thank you very much. What I wanted to share with you this morning is a handful of issues and questions that arise from them that we believe are important to consider. So let me jump right into those. Next slide, please. The first issue that I would raise with the audience and for the design community in general is the distinction between healthy architecture and healthcare architecture. We've all probably become familiar with the epidemiological triangle during COVID, understanding what it means to socially distance, to create an environment where the agent can't reach the host, and the role that filtration and masks play in breaking the triangle, breaking the spread of communicable disease. We also have learned that it doesn't apply just to health care facilities. And as has already been mentioned, it's got to be about health, not health care. By the time it's health care, it's too late. Next slide, please. So my suggestion is that the design community needs to focus on designing for health and not limit its focus to designing for health care. I love this quote by Dr. Richard Jackson, known to many around the world. He loves to challenge the architects in his audience with this question: do architects really understand that they're health professionals? And that we should understand that, because in fact we are. And as we look at the previous slide, the agent-host environment and the role that the design community can play in breaking that triangle and limiting the spread of a communicable disease, we also understand there are other health benefits that accrue from design. So that would be my first issue. Next slide. The second issue that I would raise is about managing surge capacity versus building it in versus having it as a point of flexibility or conversion. There's a cost to both. And the question arises, do we build it and not use it when we don't have surge? Do we build it and store it? Do we build it in such a way that it's disposable? Or do we simply build in convertibility for spaces? And I would argue that it's not just health care facilities that need to have convertible space. We need to think about convertibility for all of those spaces which might serve to house surge demand. They could become surge capacity. A recent article talked about the very close association, if you look at health resources and mortality rates. There was a very strong, in fact, the strongest association was between the lack of ICU beds to the unnecessary deaths of many, many, many thousands of people. So understanding how to provide ICU beds on demand, convertible perhaps, is an important issue. Next, please. The third issue that I would raise to this audience and to the greater design community is the distinction between can we do it and should we do it? This is often thought of in financial terms. This has been a very interesting time to look at COVID and its impact on healthcare, and we've had to answer the question, what's the best way to do it? And where our resources have been stretched, we've had to ask, is this the most cost-effective way to do it? Very popular emerging field called austere medicine. Many, I'm sure, are familiar with it, but for those that are not, I think it's going to be in front of us for many years to come. Already widely understood, this is the Johns Hopkins definition of it, but it means operating without the normal full range of medical resources. You see it commonly in the military, who are used to operating with austere medicine, but camping developing nations, and most recently with pandemics. We've learned how to operate without the full range of medical facilities at our disposal. Next. Please, thank you. And this is the question that I find most intriguing. During the crisis, we found austere medicine acceptable. But during normal times, the notion of austere medicine becomes anathema. We just can't imagine doing with less than the full range of healthcare services and facilities. What I wonder is, during COVID, did we decide that austere medicine was good enough? Did we change the target? Did we lower our sights at all? It's a question I think we have to address, and it could, depending on our answer, redefine the goals of our systems, our health systems. Is it about answering the question, yes, we can fix things 100%, or will we retreat to a position that we've had during the crisis? Well, we're doing the best we can, and for now, that'll have to be good enough. We've got to answer the question, is good enough maybe becoming a new target with limited resources in view? Number 4, next. The traditional or the familiar versus the research or evidence-based approach. Don't you love it when you deal with somebody who says, but we've always done it that way, versus somebody who's able to say, well, research suggests or evidence shows us clearly the best way to do it is this. In times of crisis, we're incredibly innovative. Look at how much effort has been put into new filter systems, new ways to clean the air, to exhaust the air, to purge the air, and on and on and on, new devices that we can use. Are we really understanding the full impact of that? Is this a research frontier that the design community needs to be closer to? It changes potentially. The answers change everything about how we do what we do in design and health. Next. I'm only suggesting that we need to have a research agenda. Innovation is wonderful. Limited resources are real. Can we do it? Most likely we can figure a way. Should we do it? Is the goal of good enough emerging as the priority versus we have to have everything for every procedure and for every patient? I don't like some of those implications, but as a member of the health design and health planning community, I think it's a set of questions we have to raise. So as we get to the final questions, this is the wrap up. First question from the first issue: can we as architects learn to design as health professionals on every project? Meaning, to the earlier point, can we design to protect health and develop better health and restore health once it is impaired on every project, not just health care projects, but can we embrace designing for health? Number two, can we address conversion shortages by making flexible design a best practice, not just in healthcare, but in every facility? Imagine designing a convention center with convertible facilities built in from the beginning in case it's needed for surge demand. Number three, can we embrace austere medicine as an acceptable norm? Crises demand it of us. The question is, will we adopt it voluntarily going forward in an effort to stretch limited resource to achieve the greatest good? And lastly, are architects prepared to make rigorous multidisciplinary research a centerpiece of modern architectural practice? Many are. I would submit that we all should. And with that, I'll leave the questions for discussion later. Thank you so much.
Thank you very much, Dr. Pentecost. And it may be by design that we had you as a mid-speaker there between the panel that we have today, because you've wonderfully linked everything on the spectrum from Mr. Alex Mukede's point around health versus healthcare and that challenge that posed there to our later speakers who will focus on research and innovation. So that, I feel, is a good design, and I thank the conveners of this call for helping us out in this way. So without further ado, let us now turn to my colleague here at WHO, Mr. Diarmid Campbell-Landrum, who is the head of Climate Change and Health Unit at WHO headquarters. Over to you.
Thank you very much, and thanks for the invitation to present. And as you have said, I think that this connects to many of the comments that have been made in the previous excellent presentations. So if we can go to the next slide, please. So I will be talking about climate resilient and environmentally sustainable healthcare facilities, but very much in the context of the recovery from COVID. And to go back to the comment that was made by Monsieur Mukede earlier, I think we at WHO, certainly in our department, we very much identify with the statement that most health actually comes from outside of the healthcare system. And it's very much about the environmental and social determinants of health prevention before people get sick in the first place. So the big connection that we have with COVID is not the operations of the healthcare systems themselves, important though they are, but we as WHO published a manifesto early on in the pandemic, already describing that the response to COVID was going to have to be, if we were to actually improve health in the long run, going to have to look at the environmental and social determinants of health. And our manifesto had 6 prescriptions, which you can see on this slide, and they aim to be relatively comprehensive about the overall societal response. But you can see that even within those 6 prescriptions, number 2 on ensuring basic services was basically about ensuring that we had health systems and healthcare facilities that were able to provide the basic level of need of universal health coverage services to populations. And in our terms, that means facilities which are provide the basic services, that have access to services such as water and sanitation, energy, and so on, that are resilient to climate risks, and that also play their part in reducing carbon emissions, as we now have to as a global society. Next slide, please. So again, to put this into context, we think at WHO we have 3 major objectives in responding to the climate crisis. The first is for health to play its part in driving down carbon emissions, and in doing that in such a way as to benefit health. And we think that health has some of the best arguments for why emissions should be cut, including, for example, amongst many others, improvements in air quality, improvements, more sustainable, healthy diets, and so on. But we have to get behind that drive to lower emissions. And you may be aware that healthcare globally now contributes somewhere in the region of 4 to 5% of global carbon emissions. So it's now a non-trivial contributor to the climate crisis. So we have to play our part there. The second is the second role is in protecting health from the full range of risks that climate change brings. Everything from more extreme events to infectious disease risks to sea level rise, eventually wiping out entire communities. And then the third one, and the real point of connection with this seminar, is a particular focus on health systems and facilities. Even though, as I've said, much of health comes from outside of those, that is where ministries of health, where the health sector has most responsibility and has most direct action. So we recognize that needs to be a real focus on our own business, if you like. Next slide, please. So our contribution to this is building on the experiences that are now emerging very rapidly around the world on basically bringing those things together to ensuring that we have facilities, we have systems which support universal health coverage, but which are also resilient to climate risks and which also reduce carbon emissions. Dr. Ugarte in his opening remarks referred to the smart hospitals approach in the Caribbean. We see other emerging approaches similar to those in other parts of the world. And so in October last year, we published guidance on climate resilient and environmentally sustainable healthcare facilities with exactly that goal of bringing these different objectives together. And I won't read out the text on this slide, and I'll post the link to the guidance in just a minute. But this is our attempt to basically unify those objectives and start to provide practical guidance to countries building on the experience that we've seen elsewhere. I did see a question posted in the chat in response to some of the excellent examples that were presented, I think, from Australia and New Zealand, from high-income countries. That there is, we also think that the overall approach is relevant to low-income countries, but obviously it has to be applied in a different way in countries which struggle even to supply those basic needs I referred to at the beginning. So the guidance does attempt to build a broad enough framework to do all of those things. Next slide, please. So briefly, we also recognize that healthcare facilities fit into healthcare systems. We've previously published guidance on building an operational framework for building climate resilient health systems as a whole, including preventive services and so on. And then we've basically attempted to show how it works specifically within healthcare facilities, contributes to that system-wide objective. Next slide, please. And in doing this, we, particularly around the climate resilient part, we adopt the framework that the Intergovernmental Panel on Climate Change adopts, which talks about the hazards of extreme weather events, climate risks, and so on, the exposures, the extent to which people and systems and facilities are in the way of those hazards, and then the underlying vulnerability factors. And we're basically trying to shrink all of those at the same time. So that's the approach that we adopt in trying to basically build a barrier between the increased risks that are coming, the increased damages which are coming from climate change, to build resilience for healthcare facilities and health systems more broadly. Next slide, please. I won't go through these in any detail, but just to say that we recognize that that there are a wide range of things that need to be done, and there's a wide range of guidance out there in some places in the world where I think we're at risk of producing more guidance than we have healthcare facilities. So we've tried to unify these under a series of domains. We say there are things you can do with the health workforce, there are things you need to do with water and sanitation systems, energy systems, infrastructure technologies and products, and so on. And again, we're talking about what you can do under each of those domains, both to protect from the climate risks, but also to decrease the environmental and carbon footprint of facilities. Next slide, please. I'll skip over these quite quickly, but the general message is that for each of these domains, we describe the objectives that we think need to be achieved within the health workforce. It's the most important of those, but there are others. Next slide, please. And then we provide quite detailed checklists, both to assess the risks that climate change is bringing. And we produce checklists for droughts, for floods, for heat waves, and so on, to try and empower healthcare facilities to identify their problems so they can build resilience to it.
Armin, if I could kindly ask you to wrap up. Apologies.
Absolutely. Yeah. So the next slide is just to describe that we also provide the guidance on assessing the greenhouse gas emissions and what can be done under each of those domains in order to improve environmental sustainability. And then if we go to the next slide, which I think should be the final slide, just to put this in a political context as well, many of you will be aware that this year is a really important year for climate action. We have the climate change conference coming up at the end of this year. It's always important, but it's super important this year because it's the 5-year renewal of countries' commitments to the Paris Agreement, and the UK government is making health a priority within COP26, unusually so, I would say, from the climate change side, including a particular initiative on building climate resilient health systems, but there is more than that. So we're very keen to work with you to make sure that the particular focus on healthcare facilities can be brought into the big agenda of climate change. And I'll stop there. Thank you very much.
Thank you, Dr. Campbell. This really was an incredible set of presentations that showed us everything from what countries are doing to how the challenges are being addressed, the high income contexts and the solutions being found there. And colleagues, as we move forward in this session, I'm seeing a lot of chats and comments, and I ask you and urge you to put in any questions so that they can be answered in written format in the Q&A chat box. So please, it's been a very rich interaction I'm seeing in that forum, and really encourage you all to continue this discussion and build upon these networks that have been established. So we've now heard a lot of the ideas around the lessons learned, the country's experiences. Let's now move on, colleagues, to the third session, the final session on innovation. It focuses on the technologies and research and learning. And as Diarmid mentioned, there's ways now to also introduce these concepts and build upon them in low resource settings. So we have a wonderful range of presentations coming to us from GK University School of Medicine, the International Federation of Healthcare Engineering, and Columbia University. So without further ado, it is my pleasure to invite the first speaker of this session, Dr. Sei Ochi, Associate Professor at the GK University School of Medicine in Japan, for her presentation. The floor is yours. And we can't hear you yet.
Sorry. Hello, everyone. I'm Sae in Tokyo. And today I'm talking about my guidelines for prevention of COVID-19, specifically at nursing homes. Next slide, please. And in Tokyo, as is in other countries, COVID-19 is becoming an endemic stage. And in this stage, the major places where clusters occur is at home and at institutions. And especially at among institutions, nursing homes is the place with highest risk of severe infection. Next slide, please. Because infection severity is determined by two axes, individual health risks and estimated exposure level by each action. So we can easily see that nursing care for elderly is placed as a most risky action. And next slide, please. So we think intervention in this area is one of the first priorities, but still there are several difficulties in infection control at nursing homes. Main cause mainly because nursing homes employ fewer experts in infection control compared with hospitals, and staff have less opportunity of getting training. So we think we need guidelines specifically for nursing homes and establish the guideline in last November. And in this guideline, we think prioritization of each intervention is required to prevent exhaustion of the staff. Next, please. And we assume 6 major infection routes of transmission at nursing homes. One is infection brought in from outside by staff or patients. And second is transmission between staff members at backyard. Third is one-to-one transmission between staff and patients in nursing practice. And fourth is transmission between users. And fifth is transmission between users via surface of staff when the staff, which occurs when the staff do not change gloves or change aprons. And sixth is contact transmission from the surface of common items. And among these 6 infection routes, the first one is the most difficult one. Next, please. Border control of COVID-19 is difficult. You may know it already, but because COVID-19 patients are often asymptomatic and PCR testing is not always a perfect item. So, and even more, when we set too strict border control, it may lead to the users concealing their symptoms of infection, which may cause higher risk of the spread of the infection. Next, please. And also prevention of one-to-one infection between staff and patient is difficult because distancing may decrease quality of nursing service. Next, please. So what are priorities? First priority is to prevent transmission between staff members at backyard. So our guideline focus on this area and state that staff areas such as employees' break rooms should be frequently disinfected, and employees should avoid eating meals face-to-face. Next, please. And second priority is to prevent transmission between service users via surface of staff. Such prevention is called a standard precaution at hospitals. Unfortunately, the compliance with this standard precaution is not always good at nursing homes. So we use plain words to encourage that standard precaution, like please change gloves and apron and disinfect hands after each patient's care, and do not go out to the corridor with apron or gloves. Next, please. And third priority is to prevent transmission between service users and to prevent contact transmission from the environment. But many users of nursing homes are with dementia, so it is not always perfect. Next, please. So one of the most important things we should know is none of each control measures is perfect. So deep defense, multiple layers of imperfect infection control is a key to effective and sustainable prevention measures. So our guideline explicitly states that we should understand that infection control is effective, but not perfect. Next, please. And in summary, infection control at nursing home is one of the first priorities in this endemic stage of COVID-19. And infection control, so we established the guidelines, especially for nursing homes. And in this guideline, we prioritize the control measures and multiple layers of barriers that are imperfect alone are the key to sustainable and effective prevention. Thank you so much.
Thank you, Dr. Sei-Ochi, for that wonderful presentation. I particularly like the sobering message around imperfect protection and the ways that one can deal with this. So thank you very much for that. Let us now invite Mr. Walter Vernon, who is the Principal and CEO of Mezzetti Executive member from the International Federation of Healthcare Engineering in the US. Mr. Vernon, the floor is yours.
Thank you so much, and thanks to all my colleagues on this panel and the listeners. So I am speaking on behalf of the International Federation of Healthcare Engineers. If you go to the next slide, we represent many countries currently around the world and thousands of professionals who plan, design, construct, and operate healthcare facilities. And as Dr. Pentecost suggested earlier, we do see ourselves very much as healthcare providers in important ways. We are in official relations with the WHO, and so I'll talk a little bit about that. If we go to the next slide, I wanted to show some pictures from recovery after the Bahamas. We worked with a number of hospitals and healthcare institutions in the Bahamas to think about recovery after the hurricane that passed through there a year and a half ago, 2 years ago. And we used the WHO's tools around safer hospitals, which were very effective in helping us think about some of the issues that would be faced. But one of the serious dilemmas that we faced was that many of the hospitals there were going to be, you know, even as we were reconstructing them, they were still subject to the same flooding events that were so damaging during this one. And so the reconstruction had to be done in a way that would anticipate the future climate disaster. And that illustrates so well the hard choices that we face in many ways, because we must balance climate risk and increasing and accelerating climate risk with what I might frame as financial risk. And how do we think about how to deploy design that will be effective in the face of that, but also financially effective. And now, of course, we have the pandemic risk, as well as the need to reduce our environmental footprint. So finding that balance is a very difficult thing to do. Let's go to the next slide. Over the last year, the IFHE has been working with the WHO on the COVID help desk and supplying volunteers and working with health facilities in many countries around the world and using volunteers from around the world to provide services. And in doing so, we've learned a tremendous number of lessons. In the chat a little while ago, my colleague Michaela talked about TechNate, which is a new effort of the WHO to bring together a multidisciplinary collaboration of research and design professionals, medical professionals to produce the kinds of information and collaboration and innovations that we need to respond to this really increasingly urgent set of challenges. If you go to the next slide, one of the things that's come out of that effort, WHO has been brought together people from around the world, some of the best scientists, to really focus on this question of ventilation and how do we think about ventilation as a healthcare device, if you will. Again, sort of reflecting on what Dr. Pentecost says, the building and the ventilation systems are very much a healthcare device. And so using them, and not just in the health facility, but in all places where people gather, how do we find the right designs and the right solutions that will help us preserve health and preserve human flourishing? And this is one of the tools that was produced by WHO. I think this is free and available on the WHO's website, and people should access it. It's a very good tool. If you go to the next slide, I want to talk about sort of a next step in that particular collaboration. There is a group called ASHRAE, which is a ventilation group. They focus on various research areas and standards and guidelines with respect to ventilation. They have just launched a new infectious aerosols position document task force. And here with this group, and WHO is playing a part in that. And so it will build on some of the work that's been done. And what we're trying to do is, in some ways, as suggested by Dr. Pentecost again, is bring together the idea of SORT, which is a strength of recommendation taxonomy. It's a way of looking at evidence-based medicine, and we're trying to bring the principles of evidence-based medicine to the practice of ventilation as a healthcare intervention. We're also looking at risk and risk management techniques, because we all know that there are many, many risks, and we have limited financial resources. And so one of the things we have to do is think about how do we best address the myriad of risks that we face and develop layered approaches to infection prevention, which includes architecture and engineering, but also, of course, behavioral interventions and human factors. Finally, we're trying to think about the question of resource, because not every hospital and health system has the same level of resources. And so we're trying to layer our responses based on which interventions have the greatest impact at the lowest possible cost, so that we can balance science and risk and resource to produce a set of solutions that will work for everyone. Next slide. With that, I want to thank you, and I am available for questions, and I look forward to interacting with all of you. Have a wonderful day.
Thank you, Mr. Vernon, for that presentation. And indeed, it builds upon the concepts presented around design and the multifactorial aspects that need to be considered. With that, we come to our last presentation it's my absolute pleasure to welcome Dr. Rachel Moresky, who is Associate Professor at Columbia University, New York, for her inputs. Dr. Moresky, the floor is yours.
Thank you so much. Our SID Heart Strengthening Emergency Systems program works primarily in settings with limited health resources, mainly in East and West Africa. And so that's our vantage point. But today I'm going to be talking more generally and want to really highlight the additive and overlapping impact of both COVID-19 and climate change as a syndemic on the emergency care systems, which is quite significant. These impacts are compounded, exacerbated in settings with limited health resources, and compromise the delivery of high quality, definitive emergency care systems. Advanced planning of resource allocations for the proper functioning of these complex adaptive emergency care systems is essential. Next slide, please. So the impact of both climate change and COVID overlap in both having direct and indirect impacts on the acute disease or the exacerbation of acute on chronic non-communicable diseases and injuries, primarily respiratory, cardiovascular, and mental health. This convergence can cause increased demand on facility infrastructure, equipment, consumables, and healthcare workers throughout the continuum of care, from the sub-district to tertiary facilities. Not to mention the direct mental health toll on frontline providers. At our hospital at Columbia University, New York Presbyterian in New York City, US, we were at the epicenter of the COVID outbreak, and we started an opt-out mental health service for our emergency healthcare providers to make sure that it was intrinsic into the system of a provision of care, that we were taking care of our frontline providers. Next slide, please. One example of the impact of climate change is air pollution on human health. India is a good example of this, whereas in 2019, 1.67 million deaths were attributable to air pollution. Both emergency medical disease burden and the stress of emergency care systems that result from this exposure overlap with those that are required for COVID-19 and other respiratory infections, influenza, other respiratory diseases. There is a need for higher skilled healthcare workers, but not just traditional sort of physicians, nurses, and midwives and associated clinicians, mid-level providers, but we need respiratory therapists, technicians, biomedical engineers, as well as the equipment, consumable, and drugs that are needed in conjunction with these higher skilled workers. Next slide, please. So this is our research, which we've published last week with our schematic illustrating how, in addition to the direct effects of COVID on mortality, there were also indirect effects on mortality that contributed to this excess mortality. So the impact of health service availability, services offered, utilization, and delivery contribute to these indirect effects, resulting in this excess mortality. However, a substantial proportion of these excess deaths are likely due to medical conditions unrelated to COVID that went undiagnosed or untreated during the pandemic, resulting in indirect deaths. Next slide, please. A review found that studies demonstrated that this reduction in utilization across both high and lower income countries, which were irrespective of the degree of COVID outbreak, interestingly enough, within that country or region. Remarkably, these decreases occurred not only for routine services such as child health visits, immunizations, but also emergency conditions such as myocardial infarction, stroke, as well as chronic urgent conditions as cancer. However, in this study, we did not look at mental health literature because it was large as well, so we focused on these other NCDIs. The impact of health outcomes may take years to demonstrate. Next slide, please. So here is an example of excess mortality in Mexico with the average for the last five years in 2015 to 2019 in black. And in red, you can see 2020, which starts to peak right after the Christmas holiday. And then you can see in purple in 2021 at the top where it's starting to come down. Next slide, please. And I'd like to focus on one example of a system that had a convergence between what we see in terms of the effects of air pollution and, let's say, COVID. But we know heat, extreme heat, and other climate change has also exacerbated non-communicable diseases. I just wanted to give one example of thinking about the lens, looking through the oxygen lens. Our program has done quite a bit of work on bubble CPAP and oxygen in low resource settings, really focusing at pivoting at the district hospital and regional hospital level and task shifting of healthcare workers. And I just wanted to say that while many people have been looking over this pandemic at ventilators and intensive care unit capacity, basic hospital systems must take priority, especially at the district and regional / provincial hospital level. Most of the COVID and climate change requires oxygen. We have infectious disease like pneumonia, sepsis, right? We have other non-communicable like obstetric emergencies requiring oxygen. Also asthma and heart failure exacerbated by COVID, as well as environmental impacts of climate change. And so reports of oxygen shortages have been in many countries, desperate situations. For example, in Mexico, we had considerable shortages where we saw that the price of oxygen tank was $800. That was 10 times the price in other countries in North America. And so finally, the COVID-19 Oxygen Emergency Task Force brought together organizations working under the WHO ACT Accelerator Therapeutics, the fourth pillar, as COVID surges to prevent other deaths. And that was a collaboration between Wellcome Trust and UNITAID and WHO. And there's great need to build up to the 1.6 billion target that is needed just for oxygen. Next slide, please. So looking forward, we need innovative, green, cost-effective, sustainable solutions for emergency care systems like solar power, oxygen delivery system example in this study where they built up 20 systems across Uganda in 2018 and then scaled up to DRC and Somalia. So next slide, please. Thank you so much for your time and letting me talk about that new syndemic. Thank you.
Thank you, Dr. Rachel Mareski, for that presentation. I appreciated the inputs about ways and the innovation that's coming through this, and I'm glad to see that through the ACT Accelerator, there's been a forum for this type of work, truly critical to move forward collectively. Colleagues, this brings us to the end of the presentations today in this webinar. I've certainly learned a lot. Imperfect protection portrayed as layers of Swiss cheese, oxygen delivery that is solar powered for sustainability, zero emission ambulances, the balance of health with healthcare and the scalability that our 4 country presenters are bringing and taking on board. Truly, thank you. Research and innovation are key and are part of that roadmap that we all need to see together. I appreciate all those presentations from the 3 sessions, and with great thanks to the wonderful highlights, because there is a great depth that we have not really been able to harvest today, but I'm sure the linkages will enable it. With that, thank you everyone and colleagues and participants for your involvement today. This body of work is contributing to our collective aspirations for improved health facilities. We look at this from the lens of the SENDAI framework for disaster risk reduction, the lens of universal health coverage, and the Sustainable Development Goals. And I hope you have gained knowledge, shared experiences, and strengthened the network within and intended through. We've now come to the end of the webinar. Before I turn to Dr. Stella Chungong for the closing, may I also thank and take this opportunity to say thank you to the 3 convening agencies, UNDRR, the International Hospital Federation, and of course, colleagues here at WHO for their convening role in bringing this webinar series together. Thank you all once again. It was my pleasure to be with you today, and over to you, Dr. Stella Chungong. The floor is yours for the closing.
Thank you so much, Dr. Samat. It's really a pleasure for me to be here today. Good morning, good afternoon, good evening to you all. I'm pleased to be here with you all, the panelists, the participants, at the concluding session of this COVID-19 Safe Hospital webinar series, Managing Pandemic Risks in Health Facilities. I would like to offer my gratitude and appreciation to you all for being with us throughout the series from the 28th of January to date, the 15th of April. I would like to sincerely thank our partners from the International Hospital Federation and the United Nations Office for Disaster Risk Reduction for the continued support in successfully conducting the Safe webinar series. I thank the speakers of this series from the world over for sharing their experience, knowledge, innovation, and also providing recommendations on how hospitals and health facilities across all countries can be further strengthened to more effectively manage pandemic threats and other concurrent health emergencies. Throughout this series, we have heard expert presentations from countries all over the world, including Australia, Bangladesh, China, France, Indonesia, Iraq, Italy, Germany, Kenya, Mexico, Nepal, Portugal, Qatar, Republic of Korea, Scotland, USA, and Yemen. And many of our experts have joined from the public, private, and non-governmental sectors. Many relevant specialized technical organizations and UN agencies have also participated in this webinar series. I would like to express my sincere appreciation to you all and to all the participants from the world over from hundreds of countries for their intense support, presence, and also for sharing their views throughout the Safe Hospital webinar series. Let me take you back to January this year, when we launched the webinar series with the objectives of sharing the practical experience of managing pandemic risks and lessons learned, of promoting and advocating global guidance for hospitals, of discussing challenges and opportunities of hospital services during the pandemic, and of exploring the perspective of future hospitals in applying lessons learned from this pandemic. Accordingly, the series was run off on 4 specific themes. The first around managing emergency and disaster risks in hospitals during a pandemic and hospital vaccine readiness. The second around hospital and national strategic plans for emergencies and disasters from all hazards. The third around long-term care facilities and long-term care services in hospitals during a pandemic. And the last series on health facilities post-COVID and beyond, safe, functional, climate resilient, and environmentally sustainable. Throughout the series, we have captured the lessons, innovations, good practices, and challenges from countries, hospitals, and health facilities and their experiences during this pandemic. We have also learned how countries are using WHO guidance and tools to scale up the preparedness of national health facilities and hospitals to manage COVID-19 and to continue providing essential services and non-COVID related services to the communities. We have heard of many fascinating experiences and good practices from countries. For example, those that have included the use of dual-track healthcare systems and real-time data to ensure the continuity of essential services, repurposing of existing resources in complex emergency situations, and how early involvement and investment from partners and WHO in the National Public Health Emergency Operations Centers strengthen the coordination at all levels of government to scale up the capacities of health facilities. We have also learned how gender-sensitive approaches were used to increase equity and inclusion of services, particularly in the long-term care facilities. We have taken this opportunity to share the most updated guidance and tools that WHO developed, along with its partners and experts from many countries, aiming to support the health facilities and hospitals to better prepare to respond to the current COVID pandemic. We have been extremely happy, and it has been a rewarding experience to learn how countries use WHO's guidance and tools to adapt their national guidelines for hospitals and health facilities, and to assess the capacity gaps and scale up preparedness and readiness, whilst continuing to provide and maintain essential services and adopting evidence-driven strategies to improve preparedness of healthcare facilities and hospitals. This fourth and last session of the series has been no different. We have just concluded a very rich and compelling discussion.
Stella, you've gone on mute.
So I was saying that we have just concluded a very rich and compelling discussion on health facilities post-COVID-19 and beyond. Sorry about that, my computer has been playing up all day today. Learning from this session has provided us with key information on what our future priorities could be to make health facilities and hospitals even safer and more efficient. In this session today, we have learned how to use innovation, research, and learning to make our health facilities and hospitals better prepared for emergencies and disasters from all hazards, including the impact of climate change. We also need to prioritize making health facilities environmentally sustainable and resilient. I am delighted to share some of our planned actions, taking into account the recommendations from the 4 sessions. The first and foremost action will be from our side to keep the communication lines open with all of you experts from countries, different agencies and institutions, and work with you to support member states. This is just the beginning of the conversation for us. We will develop case studies on the lessons learned and good practices that you have shared over these various sessions. And we plan to organize a global technical consultation to discuss all the recommendations and how we can use the lessons learned in reviewing and updating the technical guidance and tools. Once again, I would like to thank you, our esteemed participants, speakers, distinguished guests, moderators, our partners, the International Health Hospital Federation and the UN Office of Disaster Risk Reduction, but also our WHO colleagues for supporting this extremely important series of webinars. I will end by an announcement that was made by our Director General in a quote. He said, "This virus is presenting us with an unprecedented threat, but it is also an unprecedented opportunity to come together as one against a common enemy, an enemy against humanity." With this, I would like to close this webinar series and thank you for your time. Have a good morning, a good afternoon, and a good evening, and a good rest of the day. Bye-bye.
Thank you, Stella, and colleagues. Since it is our last webinar of the series, can I ask all colleagues to put their videos on for another photograph as we close this series? Thank you to you all. Let us take a moment to have a photograph together. It would be great to see all the faces of our presenters, who I very sadly interrupted, but feel very happy to now have your presentations to learn more and to be linked up with you as well. Thank you, everyone. Are we ready for a group photo?
Yes, we are.
Great. Big smiles. Thank you.
3, 2, 1. It's done. Thank you.
Thank you. And bye for now, everyone.
Bye.